going to kick off. So, everybody, we're really delighted to welcome you all to our Congenital Muscular Dystrophy community gathering. We've really been looking forward to this, and we really hope that the day will be of benefit and of interest to you. And primarily, the objective of a community gathering is to bring people together with experience of congenital muscular dystrophy, be it living with it or indeed being a family member or friend of somebody who has the condition. So the idea is that people can connect together and learn together, and hopefully also maybe see ways of supporting one another. So we really encourage you to chat with one another during the breaks as well. And of course we have fantastic speakers here today, which we're thrilled to welcome, and we will allow them to introduce themselves as well. So now I think we go over to Jimna, who's going to introduce the next one.
So I have the honour to welcome Dr. Reghan Foley here this afternoon at this stage. So Reghan is a senior research physician within the Neuromuscular and Neurogenetic Disorders of Childhood section at the National Institutes of Health in Maryland, the USA. She received her MD from Georgetown University School of Medicine and completed her pediatrics training at Miami's Children's Hospital and fellowship training in pediatric neurology, adult neurology and neuromuscular disorders at the Children's Hospital of Philadelphia and the Hospital of the University of Pennsylvania. Dr. Foley then completed a neuromuscular clinical research fellowship at the Dubowitz Neuromuscular Centre, UCL Institute of Child Health, and the Great Ormond Street Hospital, London, and an MD research degree at University College London. She then worked as a neurology consultant at Children's University Hospital, Temple Street, and at the Central Remedial Clinic in Dublin. Dr. Foley is now based at the National Institute of Health in the US, where she sees genetically undiagnosed patients with congenital onset neuromuscular conditions and follows children with congenital myopathies and congenital muscular dystrophies via various natural history studies. She has served as an investigator for phase 1 clinical trials in the COL6 related dystrophies, LAMA2 related dystrophies, MTM1 related myopathy, and giant axonal neuropathy. Dr. Foley is currently based at University College Cork Infant Centre and the Department of Anatomy and Neuroscience, thanks to a Fulbright Scholarship Award. Her research is aimed at identifying and validating disease-specific biomarkers in patients with COL6 related dystrophies and LAMA2 related dystrophies. We were delighted to welcome Dr. Foley here today, and we were just so thrilled to learn that she was in Ireland when we first started planning this event. Her enthusiasm, knowledge and passion in this space just oozes out in her conversations, and I'm sure you'll see that today when you're meeting and speaking with her. And we also know that there was many people who were interested in coming today that weren't able, and that's why we've taken the privilege of recording Dr. Foley's session so that it can be shared extensively afterwards with other families who weren't able to attend. So Dr. Foley's talk is entitled Congenital Muscular Dystrophies, Optimising Care and Preparing for Clinical Trials. So welcome you up to the floor and let you take away.
Can you hear me okay? Everyone hear me okay? Yeah? And I'm standing in the right spot. If I'm not standing in the right spot, you just, okay, thank you. Thank you. I'm thrilled to be here. I'm so glad to be back in Ireland. I was here working with Andrea and working with Eva, and I met Patrick when I was first here working at Temple Street in the CRC, and glad to have the opportunity to come back and be here. And I know MDI since I was first here as well, meeting you at the clinics. It was been great and fantastic to see the congenital muscle disease space and the families coming together, because it's so important. It's really important. I know typically my experience has been internationally that obviously a lot of attention to Duchenne muscular dystrophy and spinal muscular atrophy, but I'm biased to the congenital muscle diseases, in particular congenital muscular dystrophies, so I'm thrilled that you have this coordinated. I'm going to hopefully give you a comprehensive overview, but also comprehensible discussion about what's going on, and I want to pivot and make sure I cover what's most important to you. And so just to give you an idea of what I've intended to cover would be the overview of congenital muscle diseases, diagnostics, optimizing care, research, and clinical trials. Initially, we had thought there would be a lot of individuals here that also have congenital myopathy subtypes. So I think because I've kind of worked the room like a comedian before the gig, I know now who has what. I think I'm going to focus, if it's okay with you, on the conditions of the individuals who are gathered here today, which are really congenital muscular dystrophies. We have more time for more discussion. Any point in time, you feel free to just stop me. I'm going to also stop at certain points to make sure everything's understandable. This should be a back and forth. I wanted to make sure it's most useful to all of you. It's really important that you hear what's going on. There's a lot to be happy about, excited about, and a lot we've learned that I want to make sure we're going to share with you to make sure that anyone affected with congenital muscular disease is really leading their best life, and that makes me the happiest of all. Case in point, I met Patrick 2014, so proud that he's here now as a speaker, which is great. So I'm going to just go into my first slide. So just to give you some background, it was actually back in 1904 in London that the congenital muscular dystrophies were first formally described. And this is Frederick Eustace Batten, pictured here. And he worked at Great Ormond Street Hospital in London, where I had the opportunity also to train in congenital muscle diseases. And his description is actually quite accurate. He says the disease is congenital or starts in early infancy and is characterized by smallness, lack of power, and loss of tone in all the muscles of the body without localized atrophy or hypertrophy of individual muscles or groups of muscles. And very astutely he noted, very importantly, the child usually learns to talk at the normal age and intellectually is often in advance of his years. And that's really the case and really important to recognize. So we talk about the congenital muscular dystrophies, and they really are clinically and genetically heterogeneous group of disorders and characterized by, we say, congenital onset of weakness or hypotonia. And the muscle appearance is really that what we call dystrophic appearing muscle. And what does that mean is when we put the muscle under the microscope, what we see is, I don't know if you can see my arrow, but actually, oh, you can. Okay, great. I'll also point. So is it okay if I move a little bit? Yeah. So this is basically we call H&E stain of the muscle, and you're seeing here increased fibrosis or fibrous tissue. There's variation in the size of the fibers, and so in a child they should be similar sizes, but some are very big, some are smaller. Over here you have evidence of increased adipose or fat tissue. And then also over here what we see is a little bit of evidence of what we call like degeneration and regeneration of the fibers. So fibers breaking down and then regenerating. So that's kind of the typical formal definition for dystrophic appearing muscle or muscular dystrophy. And then I'd like to kind of give a framework about what we're talking about, where the proteins are that we're talking about. And so this is a schematic. It's a little bit complicated appearing, but it gives you an idea what we call the extracellular matrix of muscle, or we nickname the myomatrix. And so here's the sarcolemma, that basically the muscle membrane. Down here is dystrophin, which is involved in Duchenne and Becker muscular dystrophies. And here is alpha-dystroglycan that actually is involved in another subtype of congenital muscular dystrophy. Here is laminin alpha-2, which is myrisin, involved in myrisin-deficient congenital muscular dystrophy. And over here is collagen 4 and collagen 6. Collagen 6 is involved in Ulrich congenital muscular dystrophy, Bethlem myopathy, and also the intermediate collagen 6 related dystrophies. I should mention lamin A or lamin AC is actually internuclear, so that would actually be inside the muscle membrane in the nucleus. But I'm going to start discussion talking about collagen 6 because it's one of the most common subtypes of congenital muscular dystrophy. I know a few of you also, this is the collagen 6 is a subtype that you are most interested in for yourselves and your children. But just to give you an idea, it's a bit complicated because it is made up of 3 alpha chains. And so there's, in each of the alpha chains is coded by a different gene. So col6 alpha 1 gene codes for this chain, col6 alpha 2 gene codes for this chain, and col6 alpha 3, a very long gene and protein codes for the alpha 3 chain. Those 3 alpha chains come together and form a monomer. And it's complicated because intracellularly, then, these monomers align in an antiparallel fashion to form a dimer. Then the dimer forms a tetramer. The tetramer is then secreted extracellularly. And the reason why it's important to kind of visualize all this is any misspelling of either the col6 alpha 1, alpha 2, or alpha 3 gene will cause a change in the protein conformation. So oftentimes, there's definitely collagen 6 protein, but the conformation is a different shape. So when it's secreted, it's not going to co-localize to the basement membrane. Sorry, oops, can we go back? Previous. So it doesn't co-localize perfectly. But it's also important to notice that collagen 6 is expressed not only in the extracellular matrix of muscle, but also in blood vessels, in nerves, in the skin, in tendons, cartilage, intervertebral discs, lenses of the eye, and also internal organs. So it's multiple locations for expression. And just kind of briefly to show that in a normal muscle, collagen 6 will co-localize with other basement membrane proteins. So collagen 6 and perlecan are both basement membrane proteins, and in a muscle that's not affected by collagen 6 muscular dystrophy, they merge together perfectly. In a patient with collagen 6 muscular dystrophy, the collagen is actually often produced, but it's not co-localizing with the perlecan, but we say it's kind of in interstitial space, and you can see that better in this image from our lab. This is a confocal microscope image where here collagen is red and perlecan is green, but you see there actually is collagen 6 protein, but it's not co-localizing to the membrane itself, and that's important to recognize. There are some patients who have a lack of collagen 6 protein if it's recessively inherited. Most commonly, it's actually produced but not the right conformation, so it's not co-localizing. So the first description of the Ulrich subtype of congenital muscular dystrophy was by Professor Otto Ulrich in 1930. It's actually quite an accurate description. He described initially hypotonia and weakness notable at the time of birth, contractures of the proximal joints. If you look carefully here, there's actually this forward rotation of the shoulders, because where the pectoralis muscle inserts to the shoulder, it's a little bit tight, so the shoulders are a little bit forward rotated. There's contractions of proximal joints. You see that with the shoulders and the hips. Hyperlaxity, flexibility of the distal joints. You can see that here. Prominent calcanei, the heels are very prominent. And then there can be kyphoscoliosis, notable at time of birth. Torticollis, which is here, this tightness while the head is towards one shoulder, is very common. So one muscle, one sternocleidomastoid muscle is a little tighter, very common. And then hip dislocation or dysplasia is also common at birth. And again, the normal positioning of the hands and feet. Very commonly, the foot is flush against the shin at the time of birth. So prominent findings immediately at birth. And then it was not until 2001 that our colleagues in Italy recognized that Ulrich congenital muscular dystrophy, first described in the 1930s, actually caused by collagen type 6 protein and causative variants in the collagen 6 genes. Prior to 2001, nobody knew what caused Ulrich congenital muscular dystrophy. So that was a really important time. So we're 20 years on, and a lot's happened since that point in time. This is very generously shared by a family a young patient we have followed through the years. This was taken by the father right after birth. And what he said when we met the family in clinic is, my son had this appearance, and I went online and I figured out this is collagen 6, isn't it? And yes, it's a very classic appearance. So typically at birth there can be this elbow contractures, distal hyperlaxity, bendiness of the hands. You can appreciate over here, you can see that there is hip tightness or hip contractures, so the hips are very tight, a little bit of kyphoscoliosis there at time of birth. The same patient is in the next slide around age 2 years, and this is how he looks, absolutely adorable. And you can't tell from the still photos, but he was chatting a mile a minute. Everybody in the clinic became enamored with him. So you appreciate the prominent heels, you can appreciate kind of the rounded face, we kind of say angelic, like rounded face. Often the ears can be a little bit prominent as well. Prominent scarring can happen either pink keloid type scars or actually atrophic scarring. Like here you see this kind of scarring, that's atrophic scarring. The prominent calcanei you can appreciate in the heel. I'm just demonstrating here in this picture the flexibility of the hands and the feet, and he was not in pain when these photos were taken, but just showing you how flexible the hands and feet can be. So we've done a lot of studying, thankfully, through the years of motor function. This is just to show you, on this particular slide, Ulrich congenital muscular dystrophy, the data that was first studied in London, published 2009 in 13 patients. And then when I was in London, we were able to expand the study internationally to 75 patients. And what we learned is that independent ambulation, ambulating without any aids, was the most advanced motor milestone achieved. Some patients only acquire the ability to walk on their knees, not actually standing up, but can walk quite well on their knees. But for children with Ulrich congenital muscular dystrophy, typically loss of ambulation, meaning full-time wheelchair dependence, most typically occurs around age 10 to 11 years, some earlier. So what these are on the side are these we call Kaplan-Meier curves that show you the percent of patients that are independently ambulating, and around here would be 50%. So some children do stop ambulating earlier, but by around 10 years, half the patients stop ambulating, and the same thing with our international cohort. That's pretty consistent. And just to kind of give you also a kind of idea of the ability to rise from the floor, we've learned over time, and I'll show you some of our data, it can be predictive of future motor function. So one of our 5-year-old patients with Ulrich congenital muscular dystrophy, and she can get off the floor, but she needs the assistance of the chair. And so we often ask parents the question like, when the child rises from the floor, can they do so in the middle of the room, or do they need you to help get up, or furniture? If they need furniture to get up, that actually distinguishes Ulrich congenital muscular dystrophy from the intermediate phenotype, or Bethlem. And I'll go through that in further detail, but that's kind of the classic getting off the floor kind of maneuver it's needed, because they need more support for the proximal muscle weakness. And then we also looked very carefully at pulmonary function over congenital muscular dystrophy, and again, the cohort from London, and then the international cohort. And initially, the cohort from London, which was 13 patients, was estimating around 14 years of age patients needed to be on non-invasive ventilation in the form of BiPAP. But we did the international study, we recognized it's actually more common that by 11 years of age, non-invasive ventilation is necessary. And that's probably because we were becoming more proactive over time. We learned a lot more. We were getting patients on BiPAP when they needed it, not when it was an emergency. And that's kind of consistent since that point in time, all the data, and even our Japanese colleagues too, 11.2 years, we thought internationally 11.3 years. And so you'll hear later on in my talk, I give the BiPAP pep talk to everyone, because we want to make sure BiPAP is started proactively and not during a sickness in the ICU or a time of infection. So we're really proactive from the get-go. And I would say being proactive has literally changed our patients' lives. We don't have hospitalizations. They're off traveling the world, going to university, living their lives, and not in the hospital battling things we could have gotten around of by being more proactive. So it's really, we've learned a lot. I was upset when I was in London studying the data from some of the patients that did not get on non-invasive ventilation when they should have. They had low pulmonary function, under-recognized, and then there were lots of complications. And so now I give everyone the pep talk about BiPAP, and we've been very proactive, and thankfully it's become a different scenario. So under the umbrella of collagen 6-related congenital muscular dystrophy, at the other end of the spectrum is Bethlem myopathy, which was first described in 1976. Again, the genes were not figured out until around 2001, being the collagen 6 genes, but our colleagues in the Netherlands described it as more of an adult condition, but actually nice paper that came out in 1999 showed that actually there are symptoms of Bethlem myopathy during childhood. So if you lift the child under the arms, they probably slip through a little bit. They W-sit, so there's flexibility. So you can see these symptoms actually during early childhood as well. And there are all these typical flexion contractions of the fingers. The wrists are often tight, the elbows, and the ankles. But yes, there can be some earlier manifestations, including torticollis and low tone. Now, this is kind of be a little bit of a shift, but we recently recommended, because we're doing a lot of preparing for clinical trials, to use the term Bethlem muscular dystrophy. That's because it is actually under the umbrella of a collagen 6 congenital muscular dystrophy, and it was initially described as being benign and a dominant condition, but we've since learned that it's actually has autosomal dominant and recessive inheritance, not just dominant, and over time it's recognized the muscle, because some patients had repeated muscle biopsies, the muscle actually becomes dystrophic. And so you're going to see some papers that say Bethlem muscular dystrophy. It's kind of just semantics for us clinicians and scientists, but just so you know, it's the same condition. We're just kind of naming it to be clearer, especially as you prepare for clinical trials. And this is a picture from our colleagues in Newcastle, these photos of typical findings in adults. So you see these common forward rotation of the shoulders, the flexion contractures here of the elbows, the hands, the long finger flexors get tight, so you don't appreciate it here, but when you bend the hand back, you appreciate this tightness of long finger flexors, so inability to keep the fingers totally straight and the elbows up, and then Achilles tendon tightness. So then we move on to what we call the intermediate collagen 6 category, which we recognized when I was working in London in the international cohort. There are patients that fell between both extremes that actually had a different natural history, and it's important to recognize. So patients with the intermediate subtype actually have symptoms at birth: hypotonia, the torticollis, the hip dislocation, the prominent contractures, the hyperlaxity. But these infants typically attain the ability to rise from the floor without assistance. You saw the video of our young patient using the chair. These infants can actually rise from the floor in the middle of the room without anyone's help. So they're stronger than the Ulrich patients, but not as strong as the Bethlem patients. And I'll explain later, Bethlem patients can often climb stairs without the railing. It was important to recognize this intermediate group because these patients have a similar history to, kind of in between history to between the Ulrich and the Bethlem patients. And most of our patients were walking until about 19 years of age and then needed the assistance of a wheelchair. But most importantly, these patients have a need for non-invasive ventilation in the form of bi-level positive airway pressure BiPAP. in the late teens or early 20s, and that was under-recognized. So across the globe, there were patients that were told they had Bethlehem, didn't check the pulmonary function, wound up in the ICU, getting onto non-invasive ventilation in an emergency, and we realized, gee, this is a group that's important to recognize. You need to be proactive and do surveillance of the respiratory function. They do need non-invasive ventilation just a little bit later than the older patients who need BiPAP by around age 11. They go on in the late teens, early 20s. But if we recognize that, they do well. And just to give you an example, this patient, actually very proud of him. He's just accepted to Fordham University's drama school. So he's already been in 2 Netflix movies. He's a real outgoing extrovert, intermediate phenotypes. Just to kind of show you some of the classic findings, elbow contractures, long finger flexor contractures, but also the hyperlaxity, and the spine is actually quite straight at age 17 years there. That was about a year and a half ago. So kind of give you the overview of the spectrum. So when we kind of use nomenclature-wise, overweight congenital muscular dystrophy, patients either never walk or lose ambulation by around age 10 years, and pulmonary function is really invariable. Most patients need non-invasive ventilation in the form of BiPAP by around 11 years of age. We calculate the change each year of the pulmonary function. That's more for us when we get to the clinical trial. We say we know the natural history, we've changed the natural history. That's kind of our goal with natural history work, is what is the baseline when we give this drug? Are we changing that change? Intermediate patients, ambulation is lost by around 19 years of age, and they need to be on non-invasive ventilation by around 21 years of age. So there's a decline in respiratory function a little later than Ulrich, but still important not to miss. And then Bethlehem myopathy, now called muscular dystrophy. Patients usually walk into adulthood, but may need a walking aid in their 40s and 50s, like a walker or a cane. There are occasional patients that also need a wheelchair in their adult years. Decline in pulmonary function is variable, usually happens after age 40 years, but still should be done surveillance because there are patients who may need non-invasive ventilation earlier. The problem is we don't have a lot of natural history with Bethlehem because patients were not being checked their pulmonary function historically, so now we're being much more proactive. And then finally, we are using a probabilistic approach of predicting the future phenotype. So we see a child now in clinic, and parents ask us at a young age, Ulrich, Bethlehem, intermediate, we want to help guide them for the future. And so we did a collaborative paper with our colleagues in Barcelona. We look at the early maxillomotor milestones. So again, if the child's able to rise from the floor without assistance, or can they climb 4 steps out holding onto the railing. We had patients in Spain, 54, in the US, 65, and we could distinguish between the subtypes using the maxillomotor milestones. So for Ulrich, patients were able to arise from the floor only with assistance, like the furniture, or with a parent's assistance. Children with the intermediate subtype could arise from the floor unassisted, and those children who actually could ascend 4 steps without holding onto the railing were categorized as Bethlehem muscular dystrophy. And we used this categorization and then looked at our, basically we're looking at the forced vital capacities, all pulmonary data, looking at non-invasive ventilation use, and looking at ambulation data. You can see it's very statistically significant that this categorization does predict the future clinical picture. So again, trying to categorize patients appropriately so we have a good way to follow them and also lead in data for clinical trials. And then finally, back in 2021, the Gene Review, which is actually free accessible online, you just kind of Google in collagen 6-way dystrophies Gene Review. I had updated this review to be a very detailed, up-to-date, all the references. And the main goal was a labor of love I did during the pandemic, was to make sure that when you go to a physician anywhere in the world, you can pull up on your phone and say, this is the recommended gold standard of care for my child. And I remember when the editors were going through this, they said, well, we'll choose one reference for every point you made. I said, no, put every single reference. If 12 centers said the same thing for this one point about BiPAP, the families and the doctors need to go to the doctor and say, everyone has the same data. And the data is very kind of consistent, but this way you have the data for what you need for optimizing care. And so it also has information on diagnostics and genetics as well, but it's freely accessible and referenced up to date to 2021. So it's hopefully be a good resource around the globe. And just briefly, so I was going to talk about myrosin deficient congenital muscular dystrophy very briefly, because I don't think anyone here, that's their child's subtype. But just briefly to mention, because it is similar and it often goes with clinical trials in the same trials of collagen 6. This is a subtype of congenital muscular dystrophy that presents with severe hypotonia, axial weakness. Independent walking is often not achieved in those children who have complete loss of the LAMA2 or the myrosin protein. There are progressive joint contractures, often respiratory insufficiency, and can be a little bit of nerve involvement. And abnormal appearance of the white matter of the brain, it's not because the white matter is not functioning, it's just more water content in the white matter, and 1/3 or 30% have seizures. Just to give you kind of a quick picture. So we just published a retrospective natural history study in this condition, again, getting prepared for clinical trials starting in the next few years. One of our young patients here, 3.5 years of age, showing the, kind of the little bit of facial weakness. It's actually absolutely precious. He has a little bit of also lordotic posture and some axial weakness, and you can appreciate early contractures. So some similarities to collagen 6-related congenital muscular dystrophy. That's why a lot of our studies, Marison or Lambda-2 related dystrophy and collagen 6 come together. And then briefly, there's also a subtype called partial Marison deficiency, where children typically do ambulate independently, still have some of the contractures and the white matter findings, can have seizures, but usually the motor function is actually milder. So independent ambulation. So now getting to another subtype of congenital muscular dystrophy. This is the LMNA related CMD. This is the paper that came out in 2008 by our colleague Susanna Quijano-Roy. Prior to this time, people didn't recognize that LMNA when it occurs as a de novo change in the gene. So not inherited from mom or dad, just a de novo change in the gene. Prior to this time, people didn't recognize it caused a congenital muscular dystrophy. So LMNA is a gene where recessive variants can cause a different subtype of muscle condition, but de novo, spontaneous change in the gene cause congenital muscular dystrophy. And this was actually a really kind of a touch point moment for the whole field to recognize this. And when this paper came out, it's been a gift to the field. Dr. Quijano-Roy so beautifully described the condition, and there's kind of this classic, what we call a dropped head clinical picture. And it's such an important point to recognize, because I remember when I was working in London, there was a family in a rural area of Russia. The geneticist emailed me about a child, and the family had a website, and they chronicled their child's progression. It was the same exact clinical picture. And I asked the geneticist to please check the LMNA gene, and indeed it was that, because the clinical picture is so significant. In that same village, they went back and they pulled out other blood samples, other children that had similar presentation. They also had LMNA. So it's important to recognize and to diagnose as soon as possible. There are certain findings that are pretty consistent as well. It seems that poor weight gain is part and parcel of the condition. Even though you try to give enough calories, just part and parcel, probably a metabolic phenotype of the condition as well. And so we recognize that. We try to be really proactive with the feeding. And there's also an early dependence on non-invasive ventilation. Some centers tend to do that via tracheostomy. We use that less in the States, but if it's needed, it can be helpful. So it's kind of a kind of important discussion to have if it's needed or not. But the important thing is to recognize when non-invasive ventilation is needed and to optimize it. So working really closely with the pulmonologist to make sure the pressures are high enough so there's no early morning headaches, there's no even further decrease in appetite. And so optimizing non-invasive ventilation is a huge important component for optimizing quality of life. And the other thing to recognize is the cardiac arrhythmias can happen. So these are atrial arrhythmias. And if your cardiologist is on top of that, that's a home run, which we say in the States, or it's like winning the Liam Cup. Because you want to have a cardiologist who gets this. And I'm saying that because I have had so many patients in the States, Boston Children's, Columbia, you name it. Cardiologists say, I'm fine, I don't need to check the rhythm, and they concentrate only on the cardiac muscle, the function, but it's actually, this is the most important thing of all. So if you're on top of this, you're gonna be fine. And the thing is that the need is that you're monitoring the cardiac for arrhythmias or little pauses in the rhythm, and if you see that, if you're monitoring well and you see that, then there's actually a need for ICD, which is implantable cardiac defibrillator, and not a pacemaker. And so the issue was in the past, a lot of cardiologists put a pacemaker in. It's not good enough. And so we had to have these discussions with them over and over again. Thankfully, the team in Paris, which includes our cardiac colleagues there, Karim Wabi, I think is one of the co-authors here as well, have focused so much on this area. So whenever we have a problem with a cardiologist being stubborn, we refer them to the team in Paris for all the data that they've done in researching this. So again, cardiac arrhythmias, most important thing is being ahead of the curve, checking the rhythm. If you could do long-term Holter monitoring or the loop recorder, you're checking the rhythm, and then you're getting the ICD in place when it's needed. Also, a huge point from the team in Paris, steroids may improve muscle strength and function. And the question is dosing. So if you compile the data internationally, it's usually 0.75 milligrams per kilogram per day is what's trialed. Some teams have tried different steroid regimens, but there can be a nice response to steroids. And so the reason for that, we think, is the muscle histology has a lot of inflammation. So I remember years ago, I was in London, we were looking at some muscle biopsy slides, and there was a case who had a lot of inflammation. I mentioned to my colleagues, why isn't it LMNA? But the history wasn't classic for LMNA, and my colleagues weren't convinced. They said the muscle was too inflammatory. Indeed, it was LMNA. We published it. That poor patient was actually in rheumatology clinic for years before we pulled her over to the muscle side. There became subsequently recognition the muscle is very inflammatory in appearance, a lot of inflammation cells. That's probably why steroids are helping. I would say watch this space because a lot's being done on the research side. There could be more things coming, more therapies coming that are going to kind of work off this data as well as other data in progress coming from the team in Paris. I don't think anyone here has a child with SEPN1. Just to mention briefly, SEPN1, now actually called selenon, the gene name change, is a form of congenital muscular dystrophy as well. It used to be called rigid spine muscular dystrophy. And the important take-home point is often these children, when they're young, are crawling with their head on the ground. So a dropped head, they can't even lift the head when they're crawling. A lot of axial weakness. Over time, there's kind of this shifted kind of where the shoulders are off-center from the hips, a kind of shifted stiffness of the spine. Poor weight gain is also classic, but most importantly, significant respiratory insufficiency, even while still ambulant, so even while walking. So some teams, not here, but some teams in the States would say, oh, here she's walking, they're fine breathing-wise. No, they can have disproportionate involvement in the diaphragm and need non-invasive ventilation. One series was at by 13 years, but subsequent series are showing even younger. So you cannot be too proactive with respiratory care and non-invasive ventilation for SEPN1 or selenon-related congenital muscular dystrophy. So I'm going to probably skip over this because I don't think anybody has congenital myopathy who's here today, and I don't want to slow down from having time to have a discussion with you. I also want to ask, at this point in time, so far of what I've shown, and any major questions? Okay, and I'll have more time.
Sorry,
Yeah.
You just mentioned there for LMNA related CMD, the cardiac arrhythmias. Is
Yes.
that only in that class?
Yeah, so good point. So yeah, exactly. So I should admit that my thesis in London was on college and sixth grade CMDs, and there was a huge area where we have learned even more subsequent to that as well. We wondered, why isn't the heart involved and college and sixth is not involved? And part of that is related to regeneration, and we think collagen 6 is related to regeneration, and the heart doesn't have its own stem cells. So anyway, in a nutshell, there's no primary cardiac involvement in collagen 6-related congenital muscular dystrophy. However, if there's a need for non-invasive ventilation and it's not started, what happens is the right side of the heart, which pumps the blood to the lungs, is working really hard because the lungs are too stiff. Then you get signs of increased right-sided heart pressures, right-sided heart strain, because the heart's working too hard to pump to the lungs. Once non-invasive ventilation in the form of BiPAP is started, that heart function normalizes in collagen 6. So the heart is not involved, but there's definitely significant respiratory involvement. So we check the heart function in collagen 6 because this actually mirrors what the lungs are doing. So the lungs are happy and supported with BiPAP, the heart functions fine. But there's no progressive problem with rhythm or cardiac muscle dysfunction in collagen 6. It's only this temporary kind of shifting of the pressures if we need more non-invasive ventilation.
But at the moment for collagen 6, cardiac wouldn't be involved.
Wouldn't be involved. Yeah, we just check the echo to look more for the pressures to see if the non-invasive ventilation support is adequate. If it's not, a lot of my older patients go off to university and sometimes they need higher pressures and their BiPAP pressures are not optimized as they grow, and the BiPAP pressure is too low, and then they're still working too hard at night and the right side of the heart is working too hard, but that will normalize once the BiPAP pressure is optimized. And so even though I'm a neuromuscular specialist, I spend probably more than half my time working on optimizing the BiPAP with patients around the globe and talking to their pulmonologists, because some pulmonologists don't recognize, I have some slides on the differential involvement of the diaphragm and how much pressure you actually need to get good ventilation. And they're taking care of all sorts of conditions and may not know the actual, we look at that as disease-specific natural history, disease-specific recommendations, so you can bring that to your doctor and say, here's the natural history of this condition internationally. My child needs this, and not what you do for that patient with a different muscle condition, but for this.
So there is a protocol for that?
There is. High pressures, we use very high inspiratory pressures, exactly. And I'm going to show you in a couple slides, actually, yeah, no, of course, it's probably the biggest point of all. So my colleagues would say in clinic, you know, send Reghan in and talk to that patient. They need the BiPAP pep talk, because it is my daily thing, but it's life-changing. Once we get that right, they do well. Energy, social life, traveling, academics, professional life, driving a car, because a BiPAP is right. So we have to always kind of keep our focus on that. And I'm going to go into a whole section on that because it's really probably my favorite topic. So I'm going to skip over myopathies. They are a huge, wide discussion, and they had the similar clinical care recommendations. So I'm not going to go through the details of the congenital myopathies to save more time so we can talk about congenital muscular dystrophy recommendations and research and clinical trials. All right, so clinical trial readiness. So we talk about this because there are a lot of things happening research-wise, and why do we need to be ready? So we need to be ready because we want to make sure that there's no problem being eligible for a study and make sure the studies then can start and run smoothly. So there are 3 components of clinical trial readiness. The first is optimizing clinical care. So you're not coming to the trial not yet on BiPAP or not optimized. Identifying outcome measures. How do we measure and tell the FDA and the EMA we made a change? It's actually an important change. And we have to study natural history. So again, we say the FDA and the EMA, we know the natural history. Here's the history on the drug. And it's a key component. I've been on a few FDA advisory committee meetings where we're discussing drugs for Duchenne muscular dystrophy. And it comes down to, do you have the right outcome measure? Do you know the natural history? It's so important. And also, are all the patients optimized before they start the trial? So the first component, optimizing clinical care. And the reason is you want every participant to start from the same level of optimized proactive care. I'm going to talk about a trial we just finished at the NIH where we had children with collagen 6 and lambda 2-related CMD. Starting the trial, we did the baseline pulmonary function. We had the result. I said, oh, you're on BiPAP, right? Your pulmonary function indicates you should definitely be on BiPAP. Oh, no, we're not. So we started patients during the trial on non-invasive ventilation. So at the end of the trial, you say, what was it, non-invasive ventilation or the drug? And so we're getting ahead of the curve by making sure we optimize clinical care. And so that goes to my favorite topic. So proactive respiratory care. So this paper from 2012 by McCool et al. Talks about dysfunction of the diaphragm. So the diaphragm is this dome-shaped muscle, which is really thin, but super important in certain conditions, especially for collagen 6, but also for LMNA-related CMD. That's the weakest muscle, is the diaphragm. And so what happens in your pulmonary function report, you're told you have a restrictive lung pattern. The lungs are okay. All the congenital muscular dystrophies, lungs are okay. Lungs are okay. It's the muscles. And so what happens is the intercostal muscles can be somewhat weak, but mainly it's the diaphragm in congenital muscular dystrophies that are weak. And there's also some decreased compliance or stretching of the chest wall. And so what it is, you have extrinsic causes of restrictive lung disease, not the lungs, but it's actually the muscles. So the pattern is called restrictive, but the lungs are fine. The reason why I say that is, if you ever go to emergency room anywhere in the world, you're on vacation anywhere, and you have shortness of breath, and you have congenital muscular dystrophy, you don't want to get oxygen unless you're also on non-invasive ventilation, because oxygen is not your friend. What happens with oxygen, you only need that if you have a pneumonia, inflammation, infection. The lung tissue then needs help, but not without pressure. If you give oxygen, it will decrease your respiratory drive. The child will then be breathing even faster, and they say, oh, what happened? You need to give pressure. Always give BiPAP with oxygen, or just BiPAP alone. That's enough. Positive area pressure is enough, because you need to help the inhalation of air, exhalation of air, blowing off carbon dioxide, because you're thinking about the muscles being the problem. It's not like cystic fibrosis, not like asthma, not like COPD, and some well-intentioned teams like, oh, kind of like this or that. No, it's not a lung problem, it's a muscle problem. And so teams that are in tune to that are going to be able to optimize best your care, but you may wind up in an accident emergency room, and they want to just give an unassuming nurse puts oxygen on, just say, thank you. No, 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 only with BiPAP, never alone. And you only need oxygen usually in the setting of an infection.
I just have
Yeah.
So Ollie sometimes would have, we think it's a breathing thing, right? And I think he got prescribed an inhaler.
Yeah.
Should he be anywhere near that inhaler?
So it can help, but I'm not doing the best for him. The best thing I'm going to jump ahead and go back to it, is this here, the cough assist. I call this the miracle worker. This came on the scene when I was training in London, and it was changed the whole world for congenital muscular disease patients. So it's insufflator, exsufflator, and what it does, it alternates positive, negative area pressure, and it simulates a cough. It helps you to expectorate or bring up phlegm. That's your best friend. And so if the inhaler can open up the airways distally, really good for asthma, may help a little bit, also drives the heart rate up. It can help, but in combination with this, because this will bring up all this mucus. So we used to use it mainly during respiratory infections. Now we use it daily, actually, as a form of exercise to promote chest wall stretching, but also to bring up all the phlegm. Whenever we're in a tough spot, we use Copicus every hour on the hour. Any phlegm that's in the back of the throat will not go down to the lungs and settle there and be a problem, become a pneumonia, because you'll be getting it up and out. And so having that at home, which is now actually readily available, would be helpful. So if you do have like a kind of respiratory infection, you can use the inhaler or the albuterol, salbutamol, but only with the Copicus terms of getting basically airway clearance, bring up the phlegm, get it out. Otherwise, it settles. So that's, I do call it the miracle workers. It's really important to have that.
It's just a machine.
Machine. You put it over the nose and mouth, and it causes you to cough, and it brings up the phlegm. And children are smart. They realize actually it works. So sometimes they'll say at a certain point when they're getting a cold, they'll point to the machine. They know it'll help them to get it up and out. Yeah.
Finn uses it, and I have to say, is that different to BiPAP?
It is. Yeah.
So Finn used the cough assist machine. We've probably used it for the last 5 years. Very little, as in he hasn't needed it up to now, but it was the practice of doing it so that when we did need it, that he would be able to do it. It can be a little bit to start with, claustrophobic. It drives air in and then it sucks it back out. So the children, depending on the age of the child, it can be quite whatever. But he's 12 now, and we would have had 6 months there of a lot of respiratory problems, let's say post-op, whatever, of which this very much came into play. The pressures weren't right. He'd had a lot of pain, whatever, and then we got on the right path with it. This is most definitely one of the best interventions for outcomes.
And when you travel too, if you travel and say you're you're traveling somewhere, have it with you, because you get a cold when you're traveling. And also, if you're ever in the hospital, some hospitals say we don't have one of those. Don't worry, we brought our own. And nurses say we can't use it, it's not prescribed. It happens more in the States. I tell parents, bypass that. You just use it.
We just use it. And like that, it stops you getting to a place that's then very hard to come back from.
No, so forget that. Okay.
Yeah, it's excellent.
Yeah, it is. It's been a game changer. It's been the best friend for us and for our patients. And so we have far less problems. Even beginning of congestion, we start using it, doesn't go down to the lungs, doesn't become a lower, a pneumonia, a lower respiratory tract problem. Oops, sorry. I'm going to go backwards. So then the other thing to mention, let me just go this way actually. Yeah, there we go. Is this one here is just being proactive. So pulmonary function testing, ideally if you can do it upright and also supine lying down, that's kind of a surrogate measure of how weak the diaphragm is. So when you're upright, diaphragm has gravity, it helps you a lot. When you're lying down, there's no gravity. So you're going to see exactly how weak the diaphragm is. Differential between upright and supine or lying flat pulmonary function, if it's more than like a 20% change, you have a very weak diaphragm. We expect that, but it helps kind of just to confirm to us the diaphragm is so weak, we need high pressure with the BiPAP to overcome that weak diaphragm. Polysonogram is a sleep study. We like to do that ideally once a year. We learned during COVID, it's hard to get done, it's a problem. Guess what? You can do actually in the clinic some of these assessments that are helpful enough. So some respiratory specialists or pulmonologists use pulmonary function alone to say, hey, we need BiPAP anyway. So I'm going to talk about your forced vital capacity, or FVC, estimates your basically overall muscle strength. Once that's 50%, so 50% or lower, we know we need to be on BiPAP. So instead of waiting a year for the polysonogram, we can just start BiPAP. Some people do it in the clinic or even tweak it. You call it a PAP nap. Lay down, put the BiPAP machine on, tweak the pressure. Kids are smart. They'll say, yeah, that feels good, or no, I can't breathe out against that pressure. We need a high inspiratory pressure. By the next slide, I have that on low expiratory pressure, and then the cough assist machine in combination with BiPAP. So every night the BiPAP is needed typically, and then maybe longer during times of infection, even during the day, during all naps, you're lying down, the diaphragm needs help. And then with times of infection, you want to use cough assist and BiPAP, but also cough assist is really good for promoting expansion of the chest wall, exercising, stretching the lungs. It gets tight if you're not taking deep breaths. And so the more you use it, it's actually like physiotherapy for the chest wall. It does actually help. We know that because in one of our clinical trials, patients came back during summertime, they were like at camp or on vacation, didn't use the cough assist machine. Pulmonary function actually dipped. During band season playing wind instruments, pulmonary function is better. If they swim, holding their breath underwater, all these things help promote good pulmonary function. So we promote singing, wind instruments, swimming, all these things help. So BiPAP, I say BiPAP is your buddy, and the reason for that is, unfortunately, lots of times people are given CPAP. But for our patients, BiPAP is your buddy, not CPAP, because CPAP is continual positive airway pressure. If you have spinal muscular atrophy, that's what you want. different condition. That condition, diaphragm strong, intercostals weak. In congenital muscle disease, BiPAP is your buddy. You want a really high inspiratory pressure, really low expiratory pressure. So when you breathe out against almost nothing. You want really high pressure, inflate the lungs, breathe out against a pressure of 2 or 4. If you have continual positive area pressure, the child will say, I can't breathe out. They don't feel uncomfortable. And so always push your BiPAP in the hospital or doing an MRI scan. You actually need the BiPAP during the MRI if it's going to be 45 minutes, you're lying flat. So that's probably the biggest take-home message. You can't be too proactive. And if you're flying on a long-haul flight, BiPAP is your buddy. So I had some of my adult patients that are traveling the globe. At a high altitude, none of us can breathe that well. You're going to have lower oxygen. You're going to be struggling to breathe. Some of them faint in the flight or get off the flight and faint. You want to go on vacation, have a smooth trip, bring BiPAP, bring it into the plane with you, put it on, and sleep with it on during the flight, and then we have no problems. I mean, I'm learning because my patients are much more jet setters now with the adult ones, so travel with your BiPAP. We discussed already the cough assist, miracle worker. And then preoperative respiratory care, you can't be too proactive. And so if you're going to do scoliosis surgery, BiPAP should be established before, not during, not after, before. It's really important. The cough assist should be used daily. The Japanese did a study on this. You can optimize pulmonary function before surgery, a better outcome. So you cannot be too proactive. And the most important point is your local neuromuscular team and your respirologist or pulmonologist should speak to anesthesia, intensive care team, and coordinate respiratory care. You need an advocate to shepherd you through that whole process. You need them to know if the scoliosis surgery takes all day. Happened to one of my patients 2 weeks ago. You come out of the OR at 6 p.m., 7 p.m. Actually, you're probably better off if you've been in the OR all day, come out late at night, stay intubated probably overnight, extubate in the morning. You never want to extubate with a nighttime crew, one person at bedside. You want at bedside intensive care / anesthesia, pulmonary, neuromuscular. You're all ready, tube comes out, BiPAP goes on. Extubate directly to BiPAP, not extubate and have the child try to breathe on their own after they've been under anesthesia, probably have pain, aren't taking deep breaths. We use this approach of being really proactive, extubate to BiPAP directly during the daytime. We've had, knock on wood, no problems. But years ago, people would extubate around midnight, one person at bedside, try to reintubate, do emergency tracheostomy. Never should happen. So we just basically are just so proactive. And a pulmonary and neuromuscular talking to intensive care and anesthesia, then they all feel comfortable. They have a plan. The prepared team is the best team. And so we've had, thankfully, no problems. My little kid who was over 11 hours in the OR came out at nighttime, extubated next day beautifully, no problem. Before the OR, they were saying to Mom and Dad, he may never come off the ventilator. He came off fine. Extubated BiPAP, cough assist, fine. Singing, great. But you need to wait until they're ready. So being patient and standing between the bed, between the ICU doctor and your child, saying he or she's not ready, and having a neuromuscular team to advocate for you. And then post-operative, yeah, so basically during the daytime, ICU's there, and then directly to BiPAP. And I usually write this in an email to families, and they can forward that to all their team, just so they have it. So they can say, this is what the team says, this actually works. I had a child in London, his mom was really involved, congenital myopathy in the family trust, so it was a surgery, Royal Stanmore Hospital, it was orthopedic surgery, the ICU there insisted extubate immediately to room air. Well, he couldn't breathe on room air post-op. They were going to do a trach, and I had to convince them to transfer him to the Royal Brompton, the respiratory hospital, just to get him extubated a day or two later to BiPAP, and he was fine. So you have to, it's all about being prepared and advocating and telling ICU teams, this is a child with muscle weakness that affects pulmonary function. And then if there is a problem and you need to do repeat intubation, reattempt to extubate a few days later is usually successful. So the team may say in the ICU, like, worst case scenario, we'll never be able to extubate. Not true. It's successful. You gotta be patient. You gotta be patient. And the child will tell us when they're ready. They're not so sedated and the pain control's better and they had the BiPAP there and the cough assist. So this is kind of a visualization I was saying before. So each condition is kind of specific to the condition. So what's interesting here, these are kids who came to the NIH and did in vivo MRI. So this is dynamic breathing MRI where they're breathing deep breaths in the MRI scanner. And then, so it's yellow here is your diaphragm. And this is collagen 6, this is lambda 2. The reason for showing you this is it's different between the different subtypes. But collagen 6, you're looking at the diaphragm's moving, but not as much as the chest wall. So what happens in collagen 6, the children kind of do exaggeratory chest wall movement to break up for the diaphragm not moving. So the chest wall is really important. You put some sort of brace on for scoliosis, they can't move that chest wall. Try to get pulmonary function testing with the brace on, they can't move the chest wall. So never impede the chest wall, it's very important. Over here on the side, if you compare, so we're looking at healthy volunteers, so no muscle disease versus collagen 6. this is a diaphragm movement in collagen 6. That's healthy volunteers. That one's actually Lambda 2 or myostin deficiency. So chest wall's not moving. But then look over here. I'm sorry, diaphragm's not moving in collagen 6 compared to healthy volunteers. So what happens is they have a hyperdynamic chest wall is really moving, right? So chest wall is really moving, diaphragm's not. So we kind of tune into that. Different from myostin deficiency, it's a reverse. But knowing diaphragm is the weakest muscle is so important to advocate for the right pressures. And the stat has been helpful for that. And also for all our therapies to make sure they actually get to the diaphragm as well. Am I doing okay time-wise? Yeah. Okay. Perfect. Okay, good. So proactive cardiac care. So again, you're lucky in Ireland, you got great cardiologists. I remember phoning them from the clinic. They would see a patient the next day. They're solid. They're really, really good. But you have to help them know what to do for your child specific, because these are kind of very niche kind of conditions. It's not Duchenne, it's not SMA. These are congenital muscle diseases. So we say congenital muscle diseases, patients should have echocardiogram, EKG, and Holter. And after collagen 6, the heart function should be fine unless BiPAP's not started or it's the wrong pressures and the child's working too hard to breathe. Then the echo will show some heart strain, which will normalize on BiPAP. EKG is actually a good biomarker if you're working too hard to breathe. So kids in clinic whose heart rate's really high, parents like their heart rate's like 130, they're working too hard to breathe. So then we increase the BiPAP pressures, heart rate comes down. So it's kind of a biomarker. You say, wait, they shouldn't be so tachycardic. So that's important. And the Holter for LMNA, CMD, as I said before, careful monitoring for arrhythmias, frequent Holter monitoring, long-term Holter monitoring, loop monitoring, making sure you're ahead of the curve and you plan for the implantable cardiac defibrillator before it's an emergency. And then this is for congenital myopathies. Certain subtypes actually have problems with the heart and needing actually cardiac transplantation, but that's not congenital muscular dystrophies. Okay, so feeding and nutrition, it can be impaired in some conditions. It can be impaired certain phases of swallowing or a large tongue, not in collagen 6 or LMNA, but in Lambda 2 or myostin deficiency can be a large tongue. But recognizing the positioning of the neck and the head with swallowing is kind of delicate, and kids are smart. They're going to kind of show you what's best for them. The most important thing is to know is prolonged meal times are common. So you have to plan your family life around, like, we're going to be here for a long time. And the hard thing is at school, some of my patients, they have like 20 minutes, at least in the States, for lunch. So we plan for like, bring a shake, a high calorie shake. You can't possibly finish your lunch, especially because our patients are real big time talkers. They've talked for 20 minutes, ate nothing. So we have to figure out like a high protein, a high calorie shake for lunchtime, but at home, you're going to be there a long time. It's par for the course. It's okay because they're going to chew carefully and swallow carefully. Gastrostomy tube placement can be effective, especially if it gives you kind of that sense that it's okay if they have a fever and they're not eating well today. We got this. You had the food going in overnight. So that can be really comforting, and usually is a big kind of concern about placing a tube, but actually it's going to make you feel like not a problem. We have an extra way to get that food in place. So that's really, really helpful as well. And then orthopedic surveillance and care. So bracing for scoliosis is something which should be carefully approached. And so this is a brace actually from Garches in Paris that's actually pretty amazing, because we don't have the same thing anywhere in the States, but we can get in touch with the team there to get that support. So what's the most important take-home point is you have a window. You got to cut out for the chest wall. So here's a kind of a version on a little cute kid with a cast, not as feasible because you don't want to cast someone per se, but this is a brace where there's a chest wall cut out. You don't want to ever impede the chest wall. You want to make sure the chest wall can move really well. So you put a brace on a child that goes around the whole front chest wall. They can't move the chest wall, and they're going to need the chest wall movement because the diaphragm is so weak. So consider, if you're going to do bracing, just part of the day, not while they're sleeping, because when you're lying flat, you need to move the chest wall because the diaphragm doesn't have the benefit of gravity. So careful bracing during the daytime, maybe a little bit of time, but it has to be carefully thought out. If you do use it, just carefully, and watching pulmonary function. And then timing of scoliosis surgery is based on the degree of the curvature, the rate of progression, also how stiff it is. If the patient has a curve that's actually flexible, we have some time. But if it's getting stiff and it's getting progressed, we got to think about when we should do possibly scoliosis surgery, and the pulmonary function. They all feed in together. So it's really a planned thing. We're very proactive with pulmonary care. We figure out the timing and when it's needed. Again, we're getting everything teed up when it's needed, and then making sure that the surgeon knows the best approach, because there's certain approaches which are better approaches than other approaches for scoliosis surgery. Get your neuromuscular team always involved. This is a couple things that are available online. So Cure CMD is based in the States, but actually now it's international organization for patients and families with congenital muscular dystrophy. We did a pulmonary guide because we realized at a certain point that's the most important thing of all. Like, I could disappear tomorrow, but if this is available, you're going to be okay at bedside. So the C&D pulmonary guide was written by pulmonologists. We have about 5 of them in the States, only 5, that actually specialize in neuromuscular pulmonary proactive care. And they wrote all this down about no oxygen without BiPAP, high pressures for the BiPAP, cough assist. So it's written down by folks that can sign their name as a pulmonologist. It's harder for a neuromuscular doctor to fight this fight with pulmonologists, but pulmonologists believe pulmonologists. So the pulmonary care guide is great to have. And this is kind of more of a generalized care for congenital muscular dystrophies, talking about respiratory care, cardiac care, spine surveillance, nutrition, and physical therapy. And then we also have within each subtype of congenital muscular dystrophy these papers about natural history and like the gene review, call 6, that are extra resources that are specific to your congenital muscular dystrophy. So identifying outcome measures is the second component of clinical trial readiness. Probably not as exciting for you to hear, but it helps us to kind of identify if you're going to be involved in a study. We need to have outcome measures that are age appropriate, disease stage appropriate, that are reliable and reproducible, and measure something meaningful and sensitive to change. Probably the most important of all is measure something meaningful. When you go to the EMA and the FDA with a drug and you say their muscle strength changed from this to that, the EMA, FDA will say, what does that mean? So now we're anchoring all these changes. The child said, I can now comb my hair. Huge, home run, All Ireland, Liam McCarthy. I mean, it's the most important thing. It's meaningful, not just it changed 3 points in a scale. The child can comb their hair or feed themselves or do something easier they couldn't do before. So that's the take-home point for all this preparatory work. So we have a toolbox of different ways to measure motor function, different scales, cardiac function, pulmonary function, and then this, quality of life. Making sure that what we're measuring is important for the family and the individual who's affected with the condition. So we use different outcome measures, and in young children we have different scales. So you'll see when you go to Neuromuscular Clinic, different scales, different age ranges we use. There's one that's being trialed now, this Neuromuscular Grow, probably Andrea might have heard of, the team in Columbus, Ohio, trying to put together parts of the CHOP and 10 and parts of the Hammersmith motor scale together. And the reason for that is they want a scale that you can use from birth through all ages, because otherwise you're using one scale, the child goes out of it. So we're doing a lot of work in that space, and so I think the occupational and physical therapists have been extremely important, probably the most important in measuring change for these clinical trials. And so that's all happening as we prepare for studies. We had done a study at the NIH for patients ages 4 to 22 years, collagen 6-related dystrophy and lamina 2-related dystrophy. They came over 4 years duration every summer to the NIH. We measured the same exact outcome measures. The take-home point is we were able to measure statistically significant changes in the MFM32 scale, in the col6, the ones that are in red, and also some of the myometry, that kind of the angle of the joints. But most importantly, we're able to figure out how many patients we need to recruit for a study to show stabilization. So we can say to the FDA and the EMA, we enroll 12 patients, that's enough to show we made a change in their condition. So using all the information tells you the sample size calculations for showing basically you made a difference in change over time. Powering studies basically with pulmonary function and motor function data that we recorded over time. Yeah.
What was the intervention, or was there one?
No, sorry. So this is all natural history. So these were actually became a wonderful weekend. We brought the families every summer together for like a weekend to the National Institutes of Health, and it was 23 patients, col6, 24 lamina 2, natural history. We're just going to measure your progression through time because we didn't have that solid data, and it actually, out of this study, pulmonary function and motor function were statistically significant, and we can say we now have this written down. We're now focusing actually birth through age 5 years, so we need the early natural history, and we're doing a huge amount of focus right now on the earlier years, so we can say to the FDA and EMA, we know from birth through adulthood the annual rate of change in a child with either Ulrich, intermediate, Bethlem, Nerson deficiency, LMNA. We know these conditions by age range because actually the rate of change will change during different age ranges too. So that part's really important to define. And then I said before, making sure we now use this minimally clinically important difference. It's the take home, it's a home run. You need to make sure what you're doing is important. We figured out with our MFM motor scale what change in that scale was important for patients. And so we can say that the regulatory agencies, this change in the scale was a change that patients notice and improve their life. And so that's kind of a better way to drive home the interventions making a difference, which is actually important to the family, not just a number on a piece of paper. Exploratory outcome measures, we're using muscle imaging, biomarkers, and some remote outcome measures. I'll just briefly mention muscle imaging as we can do some quantitative things with MRI. MRI is really hard to get done in children with congenital muscle disease. The scanner is a long scan. We've used it before in Duchenne muscular dystrophy. You use some quantitative studies. We're trying to do shorter scans in the MRI we're working on. It could be quantitative, but not the simplest thing. If you need to use BiPAP when you're lying flat, you can't be in the scanner that long. So we've used a lot of muscle ultrasound, which we've been doing a lot of at bedside, and trying to do quantitative measures of muscle ultrasound, measuring the muscle size. This is the bone echo, it's the rectus femoris muscle. That's the deltoid muscle. So muscle size, echogenicity, trying to figure out ways we can quantitatively measure change in muscle. That's easy at bedside. That's not going to be a long scan. So all that work's going on in the background as well. Again, muscle MRI can be helpful, but it's a long scan and it can show patterns that are helpful diagnostically, but I'm not sure it's going to be helpful for clinical trials for young patients. Because most of the kids, I remember we did muscle MRI, one of our studies, I wound up running into the scanner to pull them out because they were crying. It wasn't worth it. It was like not worth it, not enough data coming from that to be worth it. So again, may happen in other conditions, not so much for congenital muscular dystrophies. So biomarkers is a topic that I'm very interested in because when I went to the FDA with the Duchenne muscular dystrophy studies, we were looking at urine biomarkers as being like an adjunctive data to show that we made a difference. And so I realized that if we can do either urine or blood biomarkers, not do muscle biopsies over and over again, that would be really helpful. So we want to get a biomarker which is disease relevant to the actual condition, but also disease stage relevant. So the age of the child and also the stage of their condition, capable of reflecting potential therapeutic change, whatever you're doing in the clinical trial. And then ideally provide a measure of disease and target engagement. So for the EMA and the FDA, they want to say your therapy actually changed this condition. We have data in the blood, you're actually improving these profiles about fibrosis or apoptosis, and I'll mention some of those. So we're looking at serum, urine, and muscle tissue. If you look at the actual overall muscle literature, you see in Duchenne muscular dystrophy, they've been looking at microRNAs to kind of monitor the disease severity. Looking at SMA, they use microRNAs and actually use a difference before and after nusinersen treatment. Look at actually neuropathies, they're using blood biomarkers, and also ALS. They actually use the biomarker to prove the drug. And so that's a kind of an important message. And so I was lucky to be able to, with the collaboration with colleagues at the Infant Center at Cork University Hospital, Professor Deirdre Murray, Professor Geraldine Boylan, and Darina Sheehan, I submitted an application to the Fulbright program to work with the team at Infant, as well as the Department of Anatomy, Dr. Jane English and Dr. Anna Galubeva. They do proteomics, and Infant does microRNA, and they've published on microRNA in young children that have hypoxic ischemic encephalopathy. And because of that study, they enrolled 500 healthy controls. So we had the NIH, all these blood samples taken, all these patients through the years in our freezer. We had no healthy controls. And so we couldn't do anything until we found age-matched controls. When I talked to Deirdre Murray, she said, hey, we can work together, we'll give you controls. And so I shipped my samples from the NIH to UCC, and it's all now still in progress. MicroRNA and proteomics work off of the patients with, so far the pilot's been with collagen 6 and the LAMA2 related CMDs with the healthy control patients. I think this data will be important for the field for all congenital muscle diseases and hopefully help us to succeed in future clinical trials having these blood profiles. This is data from the Infant Center that they've done beautiful work, and some of it actually has been patented for predicting the effect of hypoxic encephalopathy. So they've done probably the best work in the world, basically, in infants. And speaking to that is the International Cerebral Palsy Foundation, based off this work, gave all their funding to nowhere in the US, but UCC. So it's kind of pretty impressive. They're doing some nice work. So the proteomics is looking basically for, we're looking at using mass spec to look at relative abundance of proteins. And again, we're doing a piloting of that, and that's all underway. We're actually working with a team in Germany on that approach. And then the microRNA is looking for identifying basically the profile, and then what we're going to do then is going to validate what we found to prove that it's actually a different profile in our patients compared to the matched controls. So no one's done this work yet in congenital muscle diseases. They've done it in SMA and Duchenne. We're hoping we can also bring that forward for our clinical trials. And we also have muscle biopsy tissue as well, the NIH. So we can actually match our muscle biopsy proteomics work with the serum work as well as with the mouse work as well. So let me just see, and just want to acknowledge, so the Fulbright got me over to UCC, but the actual research is funded thanks to 7 patient organizations. Noelia is for collagen 6 in Barcelona, Col6 funds out of Boston, Cure CMD I mentioned, Impulsate is for LAMA2 out of Spain, For Sarah is a Dutch organization for LAMA2 France, and CMDTR is from Turkey. So these are your friends around the globe who are, they've actually, thankfully through Cure CMD, knew about the work that I was going to do and then helped to support it. I think I'm getting close to time, so I wondered, maybe even for the question and answer later on, I have a whole section at the end about clinical trials, so I don't know if there's another point later on I could talk about, or maybe one question and answers.
Yeah, I suppose just put it out to the group. I mean, how are you feeling? I know we're at lunchtime now at this stage, but how long do you have, Reghan?
I could talk wherever long you want.
I mean, I don't know if we'll have time to come back later on. That's
Yeah.
the only
Yeah,
thing.
yeah.
So,
What's of most interest? So I could talk about, just so you know, we had completed one clinical trial in College 6 and LAMA2. We have some other therapy work that's on the burners. What do you think? I don't know.
or do people have lots of questions that they want to ask at this stage?
I'm happy to give you some of my time if you should. Me too, but depends about the group.
Oh, okay, you okay? No one's melting or anything? Yeah, exactly. Yeah. Stretch. So I'm not going to go through the natural history because I'll say in a nutshell, we've done a lot of work on natural history, and the reason we did that was because when we learned this from the Duchenne, from those FDA panels too, if you don't have adequate natural history, FDA is going to say, how are you proving you've changed anything for any of these conditions? You just say we study this condition from birth through adulthood. This is a rate of change per those age ranges. So just to mention, we've done that work, studying the entire range of severity, deeply phenotyping studying really involved, and we've enables us to power our clinical trials and to recognize changes in the disease course. Just to mention, if any of you find yourselves in the States on vacation, want to come to the NIH, we're doing ongoing natural history work. Again, studying, as you mentioned so well, it's studying the condition, not with the therapy, but the condition naturally as it changes over time. But we have the ability to bring patients for assessment at the NIH if you're in country. We can't fly you over across the pond. We can bring you from the airport down to the NIH. You can stay and do the assessments. And Patrick's done that, so he can talk about that if he wants to. So I'll fly through that because we already have the data. I mentioned to you, we have College 6 data, we have LAMA2 data, we have other LAMA2 data. LMNA, just to mention, I'll show you this again later. We have an international study we did, and that was really helpful to look at the timing of cardiac interventions. Patients that needed cardiac interventions early typically had earlier pulmonary interventions. So this paper came out in 2021. If you don't have it, I'll send it to you just so you have it. It's kind of our best, so far, retrospective natural history study. So we're going to basically be doing a prospective study as well. But I just mentioned this is the biggest study we have so far, which is retrospective internationally on LMNA, 151 patients. But now we're doing prospective data collection, which would be probably better to have prospective collection of data over time. We're starting that at the NIH as well. But earlier intervention for cardiac typically had earlier pulmonary interventions as well. So looking at the age of nocturnal NIV and looking at the age of ICD implantation. That was pacemaker. We don't want to use pacemakers, but you're seeing some kids before age 10, but most between 10 to 20, and then similar with the nocturnal NIV starting really early. So this is looking backwards data, but we recognize now we need to be more proactive. So a lot of people have been reactive and now are being proactive. And then we did it for Selenon. Okay, and then finally just kind of mention clinical trial readiness relies on collaboration between affected individuals and families, clinicians, researchers, patient organizations like MDI, academia, federal organizations, and even some pharmaceutical companies. We have to basically give them the data they need to push forward with their research as well. And so we try to do all this work in parallel to what's happening in the preclinical space, meaning in the mouse space and the getting ready for clinical trial space. So briefly here, although I guess I have, 5 minutes or? Okay, 5 minutes. So I'm going to summarize what we have for therapy approaches in development and completed clinical trials. So one comment to make was we had published this paper back in 2008 that talks about collagen 6 is actually made not by actually the muscle itself, but these fibroblasts that are next to the muscle. And the reason why it's relevant is we need to make sure our therapies are delivered to these fibroblasts. So their muscle interstitial fibroblasts are now called fibrodipogenic progenitor cells, or FAPs. You'll just see that a lot of this research we're doing, we're making sure we have a way to monitor we got our therapy, whatever it is, expressed in the fibrodipogenic progenitor cells. So getting things to fibroblasts, because that's actually where the collagen 6 is actually synthesized. So just kind of knowing where you need to target. And that's just kind of a picture of that. And then we've had some data on mitochondrial dysfunction in collagen 6, and this compound we knew about had been in development, able to decrease early cell death. So in summary, basically, apoptosis is early cell death. We knew about this compound. It had been tested before and helping to reduce apoptotic or early cell death. And so that's kind of his background to tell you, and we had some data in the mouse model. It was not published, but showed that treating the Col6 alpha-1 mouse with this compound, omega pill, actually decrease early cell death, in particular in the diaphragm, and also help the mitochondrial appearance in the muscles. So we had some data to show, hey, we could try this medication in collagen 6. It had been trialed in a huge trial in Parkinson's, 301 patients. Unfortunately, didn't show a change in outcome, and also was trialed in ALS, basically 592 patients, and didn't show a benefit, but we knew from this data it was a safe compound to take to trial. So we did a trial at the, this is background in the Lama-2 mouse, we did a trial at the NIH, which we completed with the mega pill. It was a phase 1 study, it was open label, so everyone knew the children were getting the medication. We used sequential groups, and we studied basically two things, safety, but also pharmacokinetics. What's level of the drug in the blood over time? So lovely children who participated had an IV placed. We gave the drug. We would check hour by hour level of the drug in the blood. And we completed this study. In a nutshell, we did different low, middle, and adjusted dosing. It was a little bit complicated, meaning we had a lot of data safety monitoring, checking everything all on the way before we proceed to the next dose. So lots of checks and balances. And in summary, we just published it. The medication was safe, thank God. There were no serious adverse events, and we figured out from the study, which was 20 patients, the actual ideal dose that we get to not exceeding the target, but being on target was actually 0.06 milligrams per kilogram a day. And what's important from the study was we know now that if we go to another study, a phase 2, what dose we should use. Next question is, why is it not at phase 2? Because we've been told by regulatory agencies we need more data, we need more biomarkers. And that's what I'm working on, the biomarkers. We also need a little bit more mouse data. So that may come back for a phase 2, the mega pill, and we know it's safe, we have no dosing, but we're working on the other data, we need to bring that forward. And so we learned a lot. We also, just so you know, we had no problems recruiting among the trial. Patients signed up right away. We weren't waiting for patients to sign up. We proved to the FDA we can recruit easily for collagen 6 Lama-2. We ran a trial. It was the first interventional trial for any congenital muscular dystrophy that was run. We were able to assess safety and tolerability, and also understand the pharmacokinetics level of the drug in the blood, and show it did not accumulate, and it wasn't accumulating significantly over time. So we have a good profile for that. And we're trying to also use the muscle imaging as exploratory outcome measures. And during the study, we collected blood. So again, for the biomarkers work to say, did we change the profile of the blood during that study? I have that blood for our biomarkers work. We learned also at the time of enrollment, we need standard of care. Patients came to us that were not on BiPAP. We started during the trial. We need to also be careful. We're monitoring very frequently. Pulmonary function changed a lot. It was month-to-month visits. We had to figure out, when do we worry, when do we not worry. We don't normally do pulmonary function every single month, and so monitoring enough, doing pulmonary function, and the child's happy and awake, not when there's napping at 4 p.m. So we had to repeat a lot of things during the study to make sure the child was first thing in the morning, best possible optimized assessments, and then considering the travel burden of clinical trials, because it's hard to travel to and from sites for clinical trials. So we'll use these lessons for the next clinical trials. It was a collaborative endeavor, my team at the NIH, colleagues at UPenn in Columbia, and our colleague Francesco Montoni in London for the Safety Monitoring Board. And then we had, the compound came from Santhera, but you should know Cure CMD actually, without their funding, the trial never would have been run. So they actually gave the foundational funding to run the trial, and they also had some orphan drug development grant for FDA and endostem support as well. I'm going to probably not have more time. This actually, Patrick knows about this story, but I will maybe just in a very quick nutshell just mention the following. There are some patients with Ulrich congenital muscular dystrophy that were mutation negative, had all their testing done, and we knew they probably had Ulrich congenital muscular dystrophy, had no mutation found. And so we were able to do RNA sequencing with colleagues at the Broad Institute, which is an institute between Harvard and MIT in Boston, and found that on muscles, these patients had a deep intronic variant. We only saw on the muscle, and you can't find it on sequencing unless you go to this area of the gene in Col6 alpha-1 and you amplify this region and find this deep intronic variant. But it was such an important message because we found it on the muscle. We went back to our patients that had a diagnosis of collagen 6 congenital muscular dystrophy. We amplified that region. We now have 44 patients in this cohort, and the take-home point here is treatable because this variant typically causes a pseudo-exon to be inserted and affects the protein, but it doesn't always have that splicing outcome. Sometimes you have good splicing outcomes. So we're using these splice-modulated oligomers to induce the good outcome, to induce more collagen 6 protein expression. This work is now in a mouse model with a humanized intron 11 in it, preparing for we hope clinical trials. And then just to show you, just to brag, Patrick gave us a skin biopsy. We did a fibroblast culture. We were able to test a lot of our oligomers on his fibroblast culture in other patients. And take-home point is we actually can induce improved amount of collagen 6 expression. So this has been an important lesson for us. Bottom line is you need to get a diagnosis, know what your variant is, and then be able to figure out how best to treat it. So that's kind of ongoing work in progress. And I just want to thank, for patients, we're trying to make sure we recognize them and make sure we molecularly confirm that intron variant. Now all genetic labs are checking for this variant because they know they have to amplify that region to find that variant. And then establishing natural history. The paper came out online in March. 68 co-authors around the globe that basically shared their data on this cohort. So we're getting prepared ideally for clinical trials. We now are publishing the natural history on this specific phenotype. And to thank my colleagues, and most importantly, to thank the patients around the globe with congenital muscular disease that keep us focused on paving the road to therapy. Some of my exciting patients who have consented to having their photos shared with us. This is one of our college, our Cure CMD meetings. And then we just are looking at, I was saying this morning, we're realistically optimistic. We have a promising future. We have a lot of work we're translating into clinical trials, but we're trying to make sure we base all that work off of what we are learning from the patients and the families, and making sure what we're doing is going to be safe, most importantly, but also effective, and bringing the therapies as quickly as possible to the patients and the families. So that's my last slide. Thank you.
We've got about, I would say, 3 minutes for questions. So has anybody got any questions that they'd like to ask Reghan? There's obviously time as well at lunch if you just want to speak one-to-one. I know Reghan's very happy about that.
Where's the picture from?
Oh, yeah. So this is actually from Puerto Rico. It's a patient with collagen 6 who loves to do cruises around the world. Yeah, yeah. It's nice, isn't it? Yeah, yeah, yeah.
I have one question, just I suppose, and again, you know, it probably goes back to when you liaised with different hospitals and consultants at the time back a number of years ago. Is that still ongoing in relation to respiratory, cardiac, and all that? I suppose from my perspective, just looking at Finn has a lung function now less than 32%, which has dropped over 4 years.
Yeah.
From 78 to 32, not on BiPAP.
Okay.
On COP assist.
Yeah.
And having 4 to 5 surgeries a year.
Oh, on spinal. Spinal. Okay, with the rods.
Yeah.
Yeah. So.
And then the last 6 months in particular hasn't gone very well post-operatively from a respiratory point of view, and I do think a lot of it was to do with his lung function and that coming around.
Yeah, exactly.
Which we discussed quite heavily at the time, and it seems to be a bit disjointed.
Yeah, it's so hard.
So that's really good information.
Yeah, I would say.
You know, to be able to take time to discuss with the, you know, respiratory and orthopedic being 2 different hospitals.
Yeah.
So I don't know, is that a problem where we should be under the one?
It's around the world it is. I mean, so that's why I say I spend more time with the BiPAP. They don't liaise. I think I would say is what's so hard too is I love my pulmonary colleagues, but they're a little bit sometimes like it's fine. But then I say to them like, how many kids do you have with ulnar congenital muscular dystrophy?
No.
None. And I say to them, you know what pressures you should be using, and they can't believe it. Like, and so my adults are on BiPAP pressures of like 20s over 2, and they don't maybe see that degree of chest wall stiffness and weak diaphragm. So what I've learned from the patients, and so that's why those publications, when I send the publications on to the pulmonologists, then they say, okay, because it's incontrovertible data. They all need to be on BiPAP by around 10, 11, and we need high pressures. But if they haven't seen it, it's very different than Duchenne and SMA, so it's a whole new ballgame. So we have to kind of sometimes just share with them gently, this is what we do in this patient, and that worked really well. And they had collagen 6. It's a combination of the weak diaphragm and the stiff chest wall.
And as a result, like Finn's fatigue management, you know, he has chest pain and stuff like that, which I don't think is really due to the chest. You know, it's not the chest itself, but he has that pain. So I actually think he probably should be on BiPAP. Yeah. Okay, that was really, really interesting. Thank you so much for your time. Your wealth of information, you know, and it's always such a pleasure to have you.
Sure, I'll be around, so we can obviously chat. Yeah.
Great. Any other questions? I just have one comment. Just like at the start when you were talking about like the finding the genes, a lot have only been found in the last 20-25 years. So I'm guessing there's a lot of people out there who don't know the type of condition they have or misdiagnosed with conditions, which probably then is a factor when trying to manage them as well.
Exactly, so that's at 100%. So a lot of these genes were found in the early 2000s, and then we were doing Sanger sequencing up until like 20, even like 13, 14. Now we have these panels that are available. You can get the panel done and your first day in clinic, they send off all the genes that are applicable, the known genes that may cause the condition. You find a gene diagnosis, genetic diagnosis pretty readily and quickly before we go gene by gene sequencing. You need to recognize the condition and go gene by gene. So there are plenty of adults that are probably in Beaumont in the adult side and may not follow up because they don't know what they have. And so they don't have that sense of, like, you need to know your people, like who are people that maybe are your age, have the same condition that you could chat with as well. And also what kind of guidelines should I be following for my subtype? That's exactly what it is. It was harder to diagnose. We can say a lot's happened. Once you know how you're diagnosed, where you fit, then you have all that data for getting ready for knowing what you're eligible for therapies, but also optimizing your care and having that whole community. I can't say enough. I mean, this young man, like he had met buddies years ago during some of our studies at the NIH, and like they're, you know, best friends, you know, and my patients that are, you know, in their 30s and 40s and 50s, working full time, driving cars, wheelchair users, getting married, going on cruises around the globe. We often say in our clinic that we live vicariously through our patients. They're having these wonderful social lives. That's all because also we've been super proactive with the BiPAP and the cough assist and ahead of the curve. So we're not getting phone calls about hospitalization, but getting photos like this from their cruise, you know. And so that's where we've kind of pivoted. Once we know what they have, that's a key component. You're right.
Just thank you so much. That's great. I know there's a wealth of information there, and even just to be able to go and look back at the recording, I think again ourselves, because there's so much in it, but it was really good. And I know your time in Ireland is coming close to an end, Reghan, so it's been lovely to be able to make the connection with you and for you to make the connection with some of our community as well. So hopefully we can keep that ongoing.
No questions
You'll
there,
always be welcome to come for a visit when you're back.
Whenever.
Yeah.
I love an excuse like that.